My name is Rob McLachlan. We're here today at Prince Henry's Institute of Medical Research in Melbourne to talk with Professor Henry Burger. Where and when were you born?
I was born in Vienna, in Austria, in May 1933.
And your parents?
My father was an organic chemist in the Department of Chemistry at Vienna University. My mother met him when she was a student there, and I was an only child of the two of them. My mother was reasonably well-to-do, and I think was a baroness appointed by the Kaiser Franz Josef. Her father was in the Austrian army, and my father's father was in fact a GP.
Where did you grow up?
I grew up in Vienna for the first few years of my life, but was sent to England in 1939 and spent a year in boarding school before coming to Australia on the SS Oronsay, arriving just at the time of outbreak of war at the end of January in 1940.
And your parents?
My father had preceded us. He had been in Australia 7 or 8 months before my mother and I arrived. My mother joined the ship which I had started on in Southampton. She joined that in Naples in Italy, and the rest of the journey we made together. She rather stymied my lifestyle on board the ship because I used to assist the stewards in distributing breakfast to other passengers, and she disapproved of that activity, and so I was rather stymied from there on.
So they left everything they had in Europe?
They effectively left all that they had in Europe, although they managed subsequently to bring out some of their belongings in a very large packing case, or not quite as big as a container but not far short. And curiously, many years later, my father, who had kept the packing case, took it up to Mount Buller and built one of the very first ski huts at Mount Buller for his company's ski club.
What about your school life?
I went to school in Adelaide first, because we spent the first 3 years after our arrival in Adelaide, and I went to 3 different schools, including in 1942 being sent to a boarding school up in Mount Barker, because I think of my parents' concern about the possibility of a Japanese invasion and Japanese bombing, so I was put out of harm's way. We then moved to Melbourne early in 1943, and from then on I went to the Xavier College Preparatory School, a Jesuit school in Melbourne, and moved on up through to spend the entire school life at Xavier College.
How do you reflect upon your schooling in that place?
My memory of school is really a very happy one. It was of interest perhaps to say that, having come from Austria, but coming to a country which was at war with Germany and therefore regarded German speech and German culture with considerable distaste at the time, I found myself psychologically also developing anti-German characteristics or attitudes, and when my parents spoke German to each other in the street, I wouldn't actually walk with them. I would walk behind or in front, as if to detach myself from that atmosphere. And that actually was reflected in my last year at school, where I was doing German as a year 12 subject and didn't do very well in it, and was filled with pride when one of my oral examiners said that it was really very surprising to learn that I was actually born in Vienna. Not a sentiment of which my mother approved at all, but which I was quite proud of.
Your parents were obviously well educated. Were they supportive of your schooling?
Very supportive, and as I said, I think my time of schooling and early school life was happy. I remember pottering with test tubes inspired by my father, who was a research scientist and who came to Melbourne as research director of Monsanto Chemicals, and made, I think, an important early or mid-wartime contribution in developing a better method of synthesising sulfonamides, which were essential for Australian troops in New Guinea, particularly in treatment of infections and malaria in New Guinea. He was an inspiration to me, not only as a scientist but as a human being. He was somebody who was very popular with all around him, who related extremely well to all levels of Monsanto chemicals in Braybrook, in Melbourne. He was a very good sportsman. He'd represented Austria in hockey. He played the equivalent of league football in soccer. He was a very good tennis player and skier, and I very much looked up to him, even though I could not do any of the things nearly as well as he could in those areas. He clearly taught me to ski and taught me to play tennis, and he was an inspiration. My mother, meantime, had decided that she had to contribute to the family income, and she did a Bachelor of Arts and subsequently became a senior lecturer in French at the University of Melbourne. But my schooling was happy. The school was supportive, open, taught one to be self-critical, and I made a lot of friends there, and I believe that one of the influences that led me to do medicine rather than anything else was the group of friends whom I met and who were all determined to do medicine at that time. I also enjoyed many aspects of school. I learnt about music from a school contemporary and colleague who introduced me to many aspects, and music has been a lifelong love, particularly Baroque and classical era music, but I also like popular music. I participated in sport, but without a great deal of success, except for one 6-wicket haul against Melbourne Grammar in the under-15B cricket team. And in my final years at school, I did the equivalent of year 12 twice because I was too young to go to university after the first time, and that gave me an opportunity to do subjects that I might not otherwise have been able to do. And amongst those, perhaps the most important was English literature, where I had a superb teacher and really thoroughly enjoyed my experience of that topic. I also enjoyed physics and chemistry. The decision to do medicine was not too difficult a one. I was torn between doing organic chemistry like my father or doing medicine. It's hard to remember precisely what moved me in the direction of medicine, but certainly having a grandfather who was medical, having a close school friend whose elder brother was a doctor whom I admired, were influences, I'm sure, that went towards that.
This was a Catholic school. Has Catholicism been an important part of your life?
Catholicism was a very important part of my life. As you said, Xavier College was a Catholic school. I think it would be fair to say that we were taught in a reasonably open manner without having dogma thrust down our throats, so that one did develop a critical attitude at school, but I was, I think, what you would call quite a devout Catholic. When I was at university, I continued in that regard, and I continued in that regard when I was a resident and registrar at St Vincent's, which was just down the road from St Patrick's Cathedral, and I used to go to Mass quite frequently there. At that time, I really followed church teaching, I think, quite closely and obediently, but once I'd met my wife, she used to challenge me and make me think. She always used to say, they give you the questions and they give you the answers, and I want you to think about asking some of the questions yourself. And it was really that as a major influence that made me start to question some aspects of Catholicism.
There was a particular Jesuit priest who taught you mathematics and indeed went on to marry you, I understand.
There was a Jesuit priest called Father Wormsley J. Smith, who walked with a limp and a walking stick and who taught us mathematics and religious knowledge, and he subsequently married Jenny and myself in 1959.
In your last year of schooling, you did very well in chemistry and got into medicine. Was it difficult to get into medicine in those days?
To my best memory, no, not at all. You could actually nominate and say you wanted to do medicine. I can't remember if there was any sort of a quota, perhaps there was, but I don't think any of us from the school who wanted to do medicine failed to gain admission.
Before starting your undergraduate program, you had some interesting experiences serving your country in the national service. Can you talk about that?
Yes, at that time, national service was a compulsory part of one's late teens, particularly between school and tertiary education, and that involved going to the army camp at Puckapunyal near Seymour for a period of 12 or 14 weeks. It was a curious experience for me as somebody who had never been any part of military service at school. I'd never been a cadet or anything of the sort. Hundreds of us were taken up to the railway siding outside Puckapunyal, and our names were called as we were allocated to the various companies of which we were going to be members for the subsequent 12 or 14 weeks. And I remember standing the whole day on this siding and not having my name called. And finally there were 5 of us left on the platform, and we were informed that we were the forerunners of a company, the large part of which would be made up of boys coming from the country, from Cobram, Tokemwell, Shepparton, Echuca. And so I became a sole occupant of my platoon hut for one night before the rest of the fellows arrived from those country towns. To me, that was a very important education in human relationships, in learning to live with people who were of entirely different upbringing and educational level. I was sent immediately to a training course in order to become either a lance corporal or corporal, and when my colleagues in the hut realised what I was doing, they made quite dire threats about my health unless I came back with 2 stripes as a corporal, which thank God I duly did. One of the big pluses of that, and at the time I don't think I enjoyed national service at all, but in retrospect found it was very valuable, and one of the things that was very valuable is that we were taught to teach. We had to give lessons to the rest of the platoon, and we were taught the principles of good teaching, and I think that stood me in tremendous stead when I used to teach medical students and colleagues and graduates, etc. later.
So you entered medicine with experience in teaching, in human relations, and with a commanding knowledge of English. That was a very powerful combination for you.
Well, that was always a fortunate attribute I think that I had, that I could speak quite well and could write well. Education in Latin and Greek, I think, were important contributors to that ability, but it was a natural ability. My mother was a very good linguist, and whether there are some genes for that, I don't know, but I think that's been something that's been very helpful at all points of my career.
What about your undergraduate medical training at Melbourne University?
I did the classic 6-year medical course of the time, 3 preclinical years, a year of pathology and introductory medical studies, and then 2 full-time clinical years where I was a student at St Vincent's Hospital, an institution about which I have very warm feelings. It was a great teaching hospital, a classic clinical school, excellent clinical teaching, wonderful pathology teaching in the autopsy room. One great character, a pathologist called Alex Tate Smith, who used to rivet us with his post-mortem demonstrations. But I very much enjoyed my clinical teaching in medicine and surgery, and at the end of the medical course was actually extraordinarily fortunate in that I topped the year and got first-class honours in all the 3 major subjects and won most of the clinical prizes that were on offer at the end of that year. Some of it was quite fortuitous, but it was something which certainly allowed me to make fairly free choices about the terms I would then serve as a junior intern and a resident and registrar. I was effectively had free choice, first choice of what I wanted to do.
Can you recall any individuals who made a special contribution to your medical education, and in what areas?
One of the areas to which I could comment there was that a group of us formed a little, if you like, extracurricular tutorial group. One made a private arrangement with appropriate people to be tutored, and we had a medical tutor who was one of the senior physicians at St Vincent's, John Carl, a surgical tutor, John Connell, and an obstetric and gynecological tutor called Morris Barrett. And we met with these individuals very regularly. They were very helpful in teaching us how to learn clinical medicine and surgery and obstetrics and gynecology. But apart from that, I was certainly impressed with particularly my physician teachers. I remember the physician teachers much better than the surgical teachers, and all the senior clinicians at St Vincent's were very good teachers, as were the specialists. I do particularly remember John Billings in neurology. I very much enjoyed that as a subject and his teaching of it.
You also tutored the medical students 1 year below you. Why did you do that, and what did that give you?
I think I was asked both by colleagues at my contemporary level and also a year or two behind me to give tutes on topics as we went through. I've always loved teaching, and it was something I enjoyed doing, and which gave me quite a charge. And I think it's also a way of reinforcing one's knowledge of the topic if you've got to teach it to somebody else.
The final medical exams in those days were fairly rigorous. What were they like?
The final exams were a real test of one's stamina. We had to do a straight 3.5 days, morning and afternoon, of 7 written papers, and then the clinical exam extended over another 5 weeks, where you had to do long cases, short cases, interviews, specialty areas like paediatrics and gynecology, etc. And my preparation was perhaps a little unorthodox, but for the 2 weeks before our final exam started, I actually skied at Mount Hotham without any textbooks with me. And I found that was a fantastic preparation in terms of fitness and energy and so forth.
Now, your examiners presumably didn't know that you'd been skiing for the last 2 weeks.
I suspect my examiners didn't.
Where did the tan come from, Burger? They didn't ask you.
Exactly. I certainly was much more tan than most of my colleagues, that was true.
You obviously got most of the questions right, given that you got 10 of the 11 prizes on offer. There was one circumstance, I believe, where you were correct but the examiner was wrong. Tell us about that.
When I'd spent 25 years as director of what was then the Medical Research Centre of Prince Henry's, which we'll come to, one of the senior physicians who'd been involved in establishing that centre told a story about me that he was one of the examiners for one of the written papers in medicine. And after he'd marked the papers, which he did in conjunction with a well-known physician, William McIntosh Rose, he said to Rose, or Rose said to him, were there any outstanding papers? And Harry Garlick, who was the physician I was referring to, said yes, one. And so they compared notes about that candidate. And Harry Garlick had given that candidate 90% for one of the questions, and Bill Rose had only given him 70%. And the difference in mark was not a matter of style, it was a matter of fact in medicine and the subject of the question. And so they went back to the textbooks, and the final mark that was resolved was the 90%, and that was me. Immediately
after your medical course, you had an experience that many would be jealous of at the 1956 Olympic Games in Melbourne. That's an
one
extraordinary
of the best
experience.
jobs that I ever had, I got by courtesy of John Connell, the surgeon who had been our surgical tutor. The Olympic Games, the 56 Olympics, occurred immediately after our final exams, and Connell knew well the head of the photo finish team, which was to cover the Olympics, and they were looking for one extra assistant to help them, to work for them whilst they were in Melbourne, and Connell very kindly nominated me for that position. So I was the photo finish extra, and the highlight was the athletics at the Melbourne Cricket Ground, where a special little shed was set up opposite the finish line for all the major sprints and long distance runs, etc. And the photo finish camera somehow was up on the roof of the member stand, and this shed was in the members. And the film would be sent down a chute, and I had to collect it and then go and develop it in the in this shed, in the dark room in the shed. So I was the first to actually see who'd won any of the close races. And I worked there at the MCG for most of the Olympics. I also worked at the swimming and at the cycling, and it gave me my first exposure to competitive Olympic standard cycling.
Wonderful.
A wonderful experience, and something I would never forget.
What were your early experiences that led to your passion for endocrinology? How did that evolve?
Well, that evolved, I think, significantly later. I went from the examinations to take up a standard junior resident, as it was called then, junior resident post at St Vincent's, and we did standard 2-month terms in various aspects of medicine and surgery and emergency department, etc. And then in second year, I did a 6-month stint as medical registrar with Professor John Hayden, who was the first professor of medicine appointed to St Vincent's Hospital. He was the second University of Melbourne professor. And I spent a 2-month term with a thoracic surgeon, John Clareborough, who was one of my real role models and pin-up boys at the time, and the experience of working with him almost made me do thoracic surgery. I found him just an inspiration. But John Hayden was also an inspiration, and I went back in my third year and spent the whole year as his registrar. A very interesting and informative experience. I started a little bit of research at that time. I think I wrote my first paper when I was third year there with one of the members of the Department of Medicine. Hayden was an inspiring teacher. His ward rounds used to be populated by a significant number of people, particularly postgraduate students, and he was very clever in the way he would deal with a question to which he clearly didn't know the answer, and he usually handballed it to me and said, Burger will tell you the answer to that, or and Burger would never know the answer either, so we had to go off and look it up or admit that we didn't know the answer.
So you needed to make a decision whether to pursue a surgical career or one in internal medicine and endocrinology.
That was really a decision I had to clearly make in that third year, to make a decision as to where I would go. And it was clear that endocrinology was one specialty which was not well covered at St Vincent's. There was one man, Bill Hamilton Smith, who was the endocrinologist and diabetologist at St Vincent's. Somehow I started to get attracted to that area, talked to him, was encouraged by him to do endocrinology and to then look at having a career at St Vincent's once I'd been trained, that I would be free to take over endocrinology and develop it as a specialty at St Vincent's. So I was then directed to go and work at the Alfred Hospital, where the Ewan Downey Metabolic Unit was situated, and where Brian Hudson was endocrinologist, the late Brian Hudson, and Joe Bornstein, an expert biochemist, was also part of the metabolic unit there. So that appeared to be the optimal place in Melbourne for me to start training in endocrinology. I had hoped to spend most of the time with Brian Hudson, but he spent a sabbatical year for most of the time I was actually there, and I only joined with him for a few months before leaving to go overseas. The experience was interesting, the laboratory side of it rather frustrating and not very beneficial for me, except that it taught me patience and the need to be very careful in setting up experiments. I was then awarded an Nuffield Dominion Travelling Fellowship and went to work with the late Sir John Nabarro in London at the Middlesex Hospital. That was an excellent experience from a clinical standpoint. Again, I was given a rather unsatisfactory laboratory project on which I think I wasted quite a lot of time, until I was directed to go and work in the laboratory of Dr. Alex Kelly, an expert steroid biochemist and assayist, and that was a very productive and fruitful few months where I learnt the elements of measuring steroid hormones by the then double isotope dilution derivative assay technique, almost as long-winded a technique as the name indicates. But that led to my being able to measure testosterone in various disorders in women, and led to my first paper in the Journal of Clinical Endocrinology and Metabolism as a result of the work that I did with Alex Kelly and under John Nabarro's overall supervision, because that was an area that Nabarro himself was interested in.
So clearly you had developed an interest in endocrinology. What was it about that subject that really triggered your interest and passion?
I was attracted to endocrinology, I think, in part because of my father's background as a chemist and as somebody who worked in the laboratory and used laboratory techniques in his profession. And I saw endocrinology as a specialty which would allow me to combine clinical medicine in an area that I found interesting with laboratory technology, the need to learn and execute assays for hormones in the lab, and the possibility of that combination was one that I very much valued and attracted me, and I think that's probably why I went in that direction. I never had any cause to regret that, and found myself also with the opportunity to visit in England institutions like the Royal Postgraduate Medical School at Hammersmith, where I used to go out to their grand rounds and occasionally go on ward rounds, and was exposed to the upper echelons of English endocrinology and English general medicine at that time. But that's really was the kind of thing that attracted me.
Mm-hmm. So there you were in England, you were experiencing the very highest level of academic environment in England.
A very important event then occurred whilst we were in England, in that I was visited by the late Brian Hudson, who by that time had been appointed Foundation Professor of Medicine, Monash University, at the old Prince Henry's Hospital, which no longer exists. And Brian came to London in 1962, telling me that he'd been asked to look after a new initiative at Prince Henry's, which was to establish a medical research centre, the only hospital of the teaching hospitals in Melbourne that didn't have such an institution or research laboratory. And he asked me if I would consider being the associate director of this research centre. Well, clearly I thought all my Christmases had come at once. This was an unbelievable opportunity, I think a very precocious one when I was still very much in the raw stages of learning endocrinology, but he clearly had some sort of faith in my abilities and possibilities, and so I accepted that with alacrity, much to the chagrin of my St Vincent's colleagues who had fully expected me to come back there. I remember before leaving for London going to see the mother rectress who held all the power at St Vincent's, but who was a new mother rectress whom I had not previously known. And when I asked her could I have any assurance that I might have a future in endocrinology at St Vincent's, as had been in a sense promised to me, she said, no, I'm not going to give you that sort of insurance before I see how you get on overseas. So I bottled that piece of information, and when I was offered the Prince Henry's job, of course I accepted it with great enthusiasm. And Brian was then immensely helpful in suggesting to me that the future of endocrinology in the research field would be in the protein hormone field, not in his field, which was steroid hormones. He'd been an expert in measuring testosterone, but he was also interested in other aspects of steroid endocrinology in particular, but he said the future is in protein hormones. I'd originally planned to go and work with the late Dr. Fred Barter, who was an eminent American steroid endocrinologist in the aldosterone field, and I had to make very last-minute arrangements not to go and work in his laboratory, but to go and be trained in protein hormones. And so when we went on from London to the States, where I had a US Public Health Service postdoctoral fellowship, I went to work in a protein hormone laboratory rather than the steroid hormone laboratory
That was
for
a
which I'd originally...
very critical decision, wasn't it?
It was a hugely important decision, and it was absolutely the right advice,
Yes.
which Brian had given me. I went to work at the National Institutes of Health, and the advice to do protein hormones and protein chemistry was a very important advice. It also gave me the opportunity to learn the relatively very new technique of radioimmunoassay. Radioimmunoassay was a technique developed in order to be able to measure the very tiny concentrations of protein hormones initially. It was subsequently applied to other molecules circulating in very low concentrations, but the initial developments were particularly for insulin, a protein hormone also. And the radioimmunoassay technique was a technique which relied for its sensitivity on the employment of a radioactive label, which allowed detection of very small amounts of radioactivity, and for its specificity, because you had to be able to measure a protein in amongst thousands of other proteins with specificity. The specificity was conveyed by the immuno part, namely the use of an antibody to the hormone of interest. And the technology involved incubating a radioactively labelled form of the hormone of interest, and one of the big advances was techniques of labelling protein hormones without destroying their tertiary structure, usually with radioactive iodine, a technique that was actually introduced by two Englishmen called Hunter and Greenwood. One was able to label a purified form of the hormone with radioactivity, purify it so that you just had the labelled hormone, and then incubate the hormone with a limiting concentration of a specific and high affinity antibody. You then added known amounts of unlabelled hormone to construct a standard curve where the unlabelled hormone would displace the radioactivity from the antibody, and after that incubation you then separated the bound hormone, the radioactively bound hormone, from the free or unbound which had been displaced. And by measuring the ratio between bound and free as a function of the addition of increasing quantities of the unlabelled hormone, you constructed a standard curve, and then you incubated a serum specimen, for example, read the bound to free ratio, worked out what concentration of unlabelled hormone that was equivalent to, and that allowed you to quantitate the hormone. And that technology was introduced in about 1959, 1960, not long before I went to the States. Ultimately, it resulted in the development of an immunoassay for insulin, and my memory is that the first insulin assays were published in about 1960 or 61, and it was then applied to growth hormone. And one of the laboratories, or the laboratory that first developed a growth hormone assay, was the laboratory of Sol Burstyn and Ros Yellow in New York. And I had an opportunity to go and visit them. They worked in what was really a cellar in the Bronx, and I was amazed when I got there to find the two of them sitting surrounded by thousands of little tubes, pipetting the reagents and doing the separations and measuring growth hormone. Burstyn was an extraordinary man, probably one of the most extraordinary individuals I ever met anywhere in endocrinology. He was really a genius. He should have won the Nobel Prize, but unfortunately died before that opportunity arose. His colleague Ros Yellow did win the Nobel Prize. One of his associates, the other two people who worked in growth hormone assay with them in the Bronx were two fellows, Jesse Roth and Seymour Glick. Jesse Roth went on to a very distinguished career at the National Institutes of Health. He's still active in research and in teaching, and he was in the next laboratory to me when I worked at the National Institutes of Health in Bethesda. And I learnt the growth hormone immunoassay directly from him, and that was invaluable to me when I came back to Australia to develop the new Medical Research Centre at Prince Henry's. I subsequently encountered Burson again in 1968 on the first major overseas trip I made after my return to Australia, and I found that not only was he a superb biochemist, endocrinologist, but he was a superb historian, art appreciator, chess player, violin player, and at that time I was at a meeting in Europe, in Liège in Belgium, where the book called The Double Helix had just been published describing the structure of DNA. And he spoke about that book as if he'd been actually in the laboratory involved in all the work. He was just a most extraordinary individual.
So tell me about the Young Turks.
One of the encounters with Burson that I also observed from a distance was his participation in the annual meeting of the American Society for Clinical Investigation, which was often called the Young Turks meeting. The radioimmunoassay field and the assay of insulin was a very highly competitive area where more than one group was involved in the development, and there was another team in San Francisco, Gerald Grodsky and Peter Forsham, who were also right at the very beginning of the immunoassay for insulin story. And I was at a Young Turks meeting where Grodsky was presenting their findings on immunoassay and claiming priority, and Burson got up from the floor and attacked him in the most incredibly vitriolic terms, and I just could not believe my eyes and ears as I sat there at this Young Turks meeting watching the interchange between the two of them. And it taught me and exposed me to what's very much an American tradition of standing up and expressing your views and not being frightened and not being embarrassed to do so, which I think here in Australia we were much more anxious about.
So tell me more about your NIH experience.
As I indicated, the instruction or the advice Brian Hudson had given me was to learn about protein hormones and protein chemistry. I went to the laboratory of Peter Condliffe, who was an expert in protein hormone purification. His particular area of interest was thyroid stimulating hormone, but he also was expert across the board in protein hormone chemistry. He in turn recommended that I work with a physical biochemist, Harold Edelhock, who was really a student of protein structure, ultracentrifugation, fluorescence polarization, other techniques which one could use to study the behaviour of proteins in solution. And the protein that we decided to study was bovine growth hormone. And so I spent essentially 2 years in his laboratory learning and doing physical biochemistry. Bovine growth hormone turned out to be quite an inspired choice because it underwent spectacular changes in its fluorescence properties when it was acidified. We made studies of all sorts of aspects of the structure and function of bovine growth hormone, and as a result of my studies there, we published 3 papers in the prestigious Journal of Biological Chemistry and another one in the leading endocrine journal, Endocrinology. One of the things that I should have considered at the NIH was to do a PhD, but I learned that I would have to spend a lot of time doing coursework as part of a PhD at any of the universities closely associated with the NIH in Bethesda, Maryland, and I chose not to do that because I really wanted to maximise my laboratory and some clinical training. At the NIH at that time were a number of other giants of endocrinology. Within the area that I was in myself, Martin Rodbell, who subsequently went on to win a Nobel Prize, for his studies of second messenger signalling. Jerry Auerbach, a pioneer in the parathyroid hormone field, Ira Paston, Bob Bates, were all big names in endocrinology. The rest of the unit had people like Ed Rall, Jack Robbins, Jan Wolf, who were mainly experts in the thyroid hormone field, in which I didn't have a great deal of interest but admired them and watched them. I didn't entirely sever my contacts with Fred Barter, who was several floors below in the building where I was, and I used to attend his laboratory meetings, listen to how he planned his clinical research, and learned from him in particular the importance of what many of us called the dry run. And the dry run was a practice for presenting at meetings or for being interviewed for grants. And he was ruthless in the importance of adequate preparation, criticism by your peers, going back to the beginning and preparing it again, and finally being able to give a polished rendition of your research and your ideas and what your laboratory was doing. And that was something which I brought back with me and put into practice right from the very beginning when I worked back in Melbourne.
So you moved back to Australia in 1965 to take up that position that had been offered you by Brian Hudson several years previously.
Correct. So I came back to the Medical Research Centre, Prince Henry's Hospital, and was placed on the 11th floor of the hospital, which had a great view over the city of Melbourne and the Victorian College of the Arts. It was in St Kilda Road. The hospital has now long been torn down and has been replaced by an upmarket apartment building called the Melburnian. I was placed up on the 11th floor with some laboratory and office facilities, and the staff included a secretary and 2 laboratory technicians. I found the initial few months of being back in Melbourne quite challenging, having been in an environment where everything was available that you could possibly think of in research techniques and research facilities. Here I was really responsible for getting the place equipped and started, but one of the first things I did was to establish the growth hormone immunoassay. We went along swimmingly for a short time, and then the assay stopped working. And it took us 6 months to work out the very simple fact that in purifying the labelled growth hormone and collecting the purified fractions into tubes containing fairly concentrated albumin solution, what we were failing to do was properly agitate the tubes when the fractions were collected, so the hormone was not protected from degradation. That took 6 months to find out, but once we had that solved, then we ran the immunoassay very heavily, received samples from many different laboratories because it was the first immunoassay for growth hormone in Australia, and I fairly quickly established a collaboration with the late Norman Wettenhall, who was a paediatric endocrinologist, of whom there were very few in the world at that time. He had a big population of children with short stature in particular, and the assay technique enabled us to determine who was truly growth hormone deficient and who might then be expected to benefit from therapeutic growth hormone, preparations of which were just starting to become available at that time, particularly through the offices of one of my colleagues at Prince Henry's, Kevin Catt. Kevin was a skilled protein chemist, clinician scientist also, and with his and the efforts of a few others, we started to develop growth hormone for therapeutic use. And the assay clearly provided a way of making appropriate diagnosis in those short children. And growth hormone therapy for them was a huge boon and produced some quite spectacular improvements in their growth velocity and final height.
So you were chairman of the Human Growth Hormone Subcommittee for 15 years. Tell me about that.
Yes, at that time it was decided that the Department of Health would establish a pituitary hormone committee to guide the therapeutic use of protein hormones in Australia. It was called the Human Pituitary Advisory Committee, and it was, I think, officially a committee advising the Minister for Health. And it established 3 subcommittees: a purification subcommittee, which was charged with overseeing the purification both of growth hormone and of gonadotrophins for use in the treatment of infertility. And then an FSH committee, a follicle stimulating hormone committee, that being the main therapeutic gonadotrophin, which was established to supervise the therapeutic use of FSH in both men and women who were deficient in those hormones, and then a growth hormone committee to supervise the therapeutic use of growth hormone for children with short stature. And I became chair of the growth hormone subcommittee and a member of the Human Pituitary Advisory Committee, and served in that capacity for about 20 years. I worked with the 2 leading paediatric endocrinologists in Australia at the time, learnt an enormous amount from them, practiced in paediatric endocrinology for a time until that specialty became better established, and used to see children with short and with tall stature, and used my laboratory technology to assist that at the same time. So that perhaps illustrated a very important principle for me, that I had to be familiar with assay techniques by actually doing them myself and knowing what could go wrong and what the interpretive difficulties might be, and what limitations there might be to the interpretation of assay results, as well as seeing the clinical problems to which those assays could be applied, and having a kind of bench to bedside approach to the clinical practice of endocrinology.
Going back to those days, Brian Hudson was the chairman of the Department of Medicine, but there are many other important figures at Prince Henry's at that time.
As I mentioned, Brian was the Foundation Professor of Medicine, and he very quickly established a very vigorous, talented Department of Medicine at the old Prince Henry's Hospital. He was situated on the 6th floor of the outpatient block, whereas I came back to the 11th floor of the main block. So there was a physical separation, but that didn't prevent very close collaboration. And in his department, Ken McLachlan was the associate professor, a cardiologist, but an inspiring individual. He had people like Kevin Catt, as mentioned, Hugh Nile, of distinguished endocrine career, also Jeff Tregear, Jim Stockett, who became a leading thyroid endocrinologist, and then in other related fields, people like Jack Hansky in gastroenterology. Jack was also somebody who developed assay methods for gastrointestinal peptides. Blair Ritchie, who was a respiratory physician and physiologist of distinction. Mel Corman, a registrar who subsequently moved into the gastroenterology field as well. It was a distinguished and very active group, and we did a lot of collaborative research and prospered the department and the Medical Research Centre at the same time.
When you look back on the achievements at Prince Henry's Institute in those days, what do you reflect about?
A very important milestone for me was the recruitment of my first medical postgraduate scholar, a man called Don Cameron, who came down from Queensland and who enrolled to do an MD, and he decided that he would work on human growth hormone and to determine how growth hormone was handled in the body, the so-called metabolic clearance of growth hormone, its secretion rate, its disposal in the circulation. And Don enrolled and joined me in 1967, and that really was when I think the Medical Research Centre took off. A couple of years later, the late Yogesh Patel, a Fijian Indian who was a New Zealand medical graduate, came to join us. Yogesh was an extraordinarily brilliant individual. He decided he wanted to work in the thyroid field, and so he established or made much more sensitive an existing assay for thyroid stimulating hormone. At the time he joined us, that assay could not distinguish the lower limit of normal from a suppressed value. And in thyroid disease, it was very important to be able to make a diagnosis of hyperthyroidism or thyrotoxicosis. And one of the ways to do that in principle was to be able to show that a patient had a suppressed thyroid stimulating hormone because of the autonomous activity of the thyroid gland over-secreting and suppressing the pituitary. Yogesh made the existing TSH assay much more sensitive and enabled us to measure suppressed levels of TSH and distinguish them from the lower limits of normal. He also developed one of the first assays for the second thyroid hormone, triiodothyronine or T3, and with the combination of standard T4 assay, T3 assay and TSH, we did a lot of studies of thyroid physiology and thyroid pathophysiology. And Yogesh went on to have a distinguished career overseas. He went to work in Geneva with a man called Lelio Orci, who was a pioneer of the cellular localization of hormones and their transport intracellularly. And ultimately Yogesh went to Montreal to become Professor of Medicine and become the world expert on somatostatin, the hormone which inhibited the release of growth hormone. He died very young at the age of 61 or 62, a very sad occurrence. From there on, a number of other people joined the research centre, including Frank Alford, who became the main endocrinologist at St Vincent's and who also joined us to do studies of growth hormone. Gordon Baker, who became a distinguished professor of andrology, was my first endocrine registrar. And I didn't mention that fairly early after my return, not only was I charged with running the Medical Research Centre, but also becoming head of the Hospital Department of Endocrinology. And we were allowed to appoint our first endocrinology registrar in 1970, and that was Gordon. And Gordon subsequently stayed at Prince Henry's and became a PhD student and did a masterly PhD on the endocrinology of liver disease under the joint supervision of Brian Hudson, David de Kretzer and myself. So he was another distinguished member of the team who contributed enormously to our studies of pituitary hormone secretion. We studied the 24-hour patterns of secretion and looked at the pulsatility of pituitary hormone secretion. Yogesh's assay allowed us to show that thyroid stimulating hormone had a circadian rhythm, just as did some of the other pituitary hormones. Other members of the laboratory at that time included a biochemist, Terry Belair, and subsequently another, Adrian Harrington, who studied all sorts of aspects of the mechanism of action of growth hormone and its binding to a growth hormone receptor. In turn, after that, I was joined by David Healy, who was subsequently to become Professor of Obstetrics and Gynecology at Monash. He came to do a PhD on prolactin, so my interests diverted to that. And I think all that, in a sense, represented the fact that my philosophy in running the Medical Research Centre, fortunately backed up by the fact that people expressed a wish to come and work with us, was to use the talents of people to the maximum and to allow them to decide which hormone, which direction they thought was appropriate, and that resulted in us being a highly productive research institute, ultimately to become that, in quite a number of aspects of endocrinology. In the meantime, I was also joined in 1974 by David de Kretser, who spent several years on our staff as a senior research worker, and that actually continued a collaboration I'd begun with David before he really joined us, and of which the pinnacle was the isolation and purification of the hormone inhibin.
The story of inhibin is a fascinating one and a major component of both your life and also my life. It's really a triumph of basic science and clinical connection, what we now call translational research. Perhaps you should tell the story.
David had as his special area of interest the testis, the structure and function of the testis, and he'd undertaken postgraduate training in Seattle at the direction of Brian Hudson, who was really our mutual endocrine father. And David had come back, and in the interim I had established, among other things, immunoassays for the two pituitary gonadotrophins, follicle stimulating hormone and luteinizing hormone. And we applied those assays to the study of men with infertility in particular, and found that men with some forms of male infertility had a hormonal pattern with an elevation of FSH, but normal levels of testosterone and normal levels of the other pituitary hormone that controlled the testis, luteinizing hormone, or LH. The fact that there was an isolated elevation of FSH indicated that there must be another factor produced by the testis which was lacking in men with testicular or with some forms of testicular disease. That hormone had been postulated as a hormone 40 years earlier by workers in the United States. Various groups had made sporadic attempts to purify that substance, which had been called inhibin. The original introducer of that was somebody called McLachlan, and the term inhibin was really a concept rather than an actual entity because nobody had been able to purify it. And when we were convinced that such a hormone must exist from our radioimmunoassay studies and the studies of other laboratories around the world, we set out to explore whether we might be able to isolate this hormone, because it was one of the big unanswered questions in reproductive endocrinology. Victor Lee and Ted Keogh, who was one of my subsequent early registrars, extracted bovine testes and infused those testicular extracts into castrate sheep, and showed that those sheep which had elevated FSH levels had their FSH levels suppressed but not their LH levels by the infused testicular extracts. Again, a result which indicated that those extracts must contain this substance. Our research was also supported by observations from another individual who was very influential on me as an endocrinologist at the time, a Belgian endocrinologist called Paul Franchimont. In 1968, when I made my first big overseas trip after returning to the Medical Research Centre in 1965, in 1968, Paul Franchimont ran a protein and polypeptide hormone conference in Liège in Belgium and invited me to participate in that. I met him, was immediately struck by his enormous charism and his enormous abilities in endocrinology. At that time I was starting to consider where I might take a sabbatical, because I would become due for a sabbatical 2 or 3 years later, and I decided that if he would have me, I would go and spend a year in his laboratory in 1972-3. Paul was somebody else who was interested in the inhibin concept and whose laboratory was also very early in establishing an FSH assay. And he too had made the observation about infertile men in papers that were published almost simultaneously by him and from our group in Melbourne. And he had started to do work. He was an extraordinarily innovative endocrinologist who asked the simplest of questions and used the simplest of technologies to answer them. And he took castrate rats and he injected them with seminal plasma from normal individuals and showed that the seminal plasma suppressed FSH. And he then took seminal plasma from men with infertility and azoospermia and showed that their plasma didn't suppress it. So he also was very convinced that there was an inhibin and that would be possible to isolate it perhaps from seminal plasma or some other source. Regrettably, from his point of view, he didn't finally succeed in what then became a competitive race to be the first to isolate inhibin, but this provided additional material and provided me with a year of exposure to his thinking and his technologies, which I also found invaluable. Then, having come back from that sabbatical and continuing the collaboration with David, having shown that these testicular extracts would suppress FSH, we went on to try and purify the activity. An important next step was to find a simpler way of assaying the extracts than infusing them into castrate sheep. And an important early person in that was a man called Larry Eddy, who worked at the Howard Florey Institute, to which Brian Hudson had gone in 1972, having resigned the chair of Benson at Prince Henry's and going up as a senior research fellow to the Howard Florey, where he was joined by Hugh Nile and Jeff Tregear, both eminent protein chemists, and Larry Eddy, who developed a cultured pituitary cell assay in which inhibin-containing or putatively inhibin-containing extracts would suppress the stimulation of gonadotrophin secretion by those cultured cells when they were exposed to the fairly newly discovered luteinizing hormone or gonadotrophin releasing hormone, GnRH. Late in the 1970s, I was joined by a research fellow from New Zealand called Russell Scott. And Russell Scott, in conjunction with one of our technicians at the Medical Research Centre, Helen Quigg, and by me as a supervisor, established a cultured pituitary cell assay which worked even better than the Eddy assay, and we then applied that assay to monitoring the purification of inhibin. We worked at that time, David de Kretser and I at Prince Henry's, Brian Hudson and his team at the Florey, collaboratively in the attempt to purify inhibin, by that stage using what was called retitestis fluid from the lymphatics which drained the testicle as a better source than whole testicular extracts, which were very messy. And the collaboration worked in the sense that the protein chemistry was done at the Howard Florey and the assays were done by us with Russell Scott and his cultured pituitary cell assay. Late in, I think, 1978, when that collaboration appeared to be going quite well, David and I received a visit from the late Brian Hudson, who said that the Florey group felt that they weren't progressing as fast as they would like to, and that some of that delay was due to the fact that we were taking longer to do the assays than they were happy about, and they had therefore made the decision that we would terminate the collaboration amicably, that we would continue to use the same extracts from retitestis fluid as some sort of biological standard, but they would proceed alone with the purification technique.
How did that make you feel?
Well, David de Kretser and I actually couldn't believe this discussion
Your mentor.
at first, but I think in the wake of Brian's leaving my office at Prince Henry's, we looked at each other and said, we'll beat them. And so we, David and I together, pursued the purification. We decided that it would not be appropriate to use the same starting material as they were using, and it had become clear then that there was a similar activity in follicular fluid from the ovary And therefore, because bovine follicular fluid could be readily collected at the abattoir, we used bovine follicular fluid. The other crucial aspect of that was that we were joined by David Robertson. David had had an extensive training at the Karolinska Institute in Stockholm in Sweden, was a rigorous, careful, dedicated protein chemist and assayist, and David was crucial in the progress we then made in purifying inhibin from follicular fluid. It was a very difficult protein to purify. It kept on disappearing from column chromatography, attempts at separating it from other proteins. A lady called Marion Dobos worked with us in the early 80s and applied reverse phase column chromatography to the purification and succeeded in partial purification of what was in fact ovine follicular fluid inhibin at the time. We were assisted by Milton Hearn, who was a chromatography expert in protein chromatography, and also by Frank Morgan at St Vincent's, who was a protein chemistry expert, illustrating the fact that we had a wide collaboration in this attempt to purify inhibin. David and I led the team from Prince Henry's, and he subsequently from the Department of Anatomy at Monash, to which he moved in 1978 or 79. And we had regular team meetings with all the main players. We kept rigorous accounts of what we were doing, and the project proceeded slowly but in a generally successful direction until 1984, when we felt we had succeeded in our mission.
So do you remember a eureka moment with inhibin where you knew you had it?
I don't remember a eureka moment. There must have been one.
I can. I can remember the gel, a silver stained gel showing a homogeneous band, and David Robertson was uncontrollably excited.
Certainly we reached electrophoretic purity of a molecule which had the inhibin properties. We first submitted our work to the American journal Science because we thought this was a very important breakthrough discovery. The isolation of a new hormone in reproductive endocrinology was a pretty major achievement. And Science held on and held on and held on, and we didn't get an answer. We started to become a little suspicious that one of the referees for the paper might have decided that this was a real plum and that they just might quickly see if they couldn't duplicate the technology which we'd submitted. We weren't really very used to dealing with prestigious American journals, but I finally plucked up courage on a trip to the States after Science had had the paper for about 4 or 5 months, and I rang the editor of Science and he said, no, we still haven't made a decision. And I said, well, I'm sorry, I wish to withdraw the paper. We just cannot hang on forever and ever to have this published. And we then made a decision to go for a much quicker, less prestigious journal, Biochemical and Biophysical Research Communications. We submitted it there, it was accepted within a few weeks, and we published about 3 weeks ahead of the main Japanese competitors who also had isolated inhibin more or less at the same time. But we actually had the Science prize, we actually had got there first. We should have got there first also to the cloning of inhibin, which turned out to have 2 subunits, but one of our collaborators in amino acid sequence analysis had made an error in the sequence of one of the 2 subunits. And that meant that we actually were frustrated, and we were beaten to the cloning by Hugh Nile, in fact, working in the United States at that time. But we also then went on with the purified hormone to generate antibodies. I think David Robertson was crucial in that, and I think you as interviewer were also crucial in that. And you and David, in fact, developed a radioimmunoassay for inhibin. In retrospect, we realised that that was a radioimmunoassay which generically recognised inhibin, which was subsequently shown to exist in two forms, and the assay probably mainly reflected inhibin A, but you had joined us as a PhD student and really the world was at your feet because you had a new hormone, a new assay in which you'd participated in the development, and now you could go out and apply it to almost all areas of reproductive endocrinology, male and female, which you indeed did with great distinction. And so we were able to publish jointly a whole series of papers on the physiology and the pathophysiology of inhibin. Perhaps the next big step that occurred, in the interim several people had joined the lab to study inhibin control and the control of the inhibin genes in the test tube, etc., including people like Susan Davis, who did her PhD in that area and went on to a distinguished career in female reproductive endocrinology. A crucial meeting occurred when I met a Dutch gynecologist at an international congress in about 1987 or 88. I don't remember the specific meeting, but he said, look, you guys are publishing measurements of inhibin. I have a series of patients who have a rather uncommon ovarian tumour called a granulosa cell tumour, but as you have now shown that granulosa cells are the source of inhibin, my prediction would be that patients with granulosa cell tumours would have high inhibin concentrations. I've got a whole lot of sera in my freezer, would you be willing to assay them? I very enthusiastically agreed to do that, and he was absolutely correct. The patients with GCTs, as they were abbreviated, had very high inhibin levels, and he had collected serum from patients whose tumours recurred only a year or two later, and we showed that the inhibin assay would actually predict tumour recurrence up to 18 months or 2 years ahead of the actual recurrence being clinically detectable. And we published a paper in the New England Journal of Medicine on the elevated inhibin levels of patients with granulosa cell tumours.
How's that area now progressed?
That clearly provided a very important practical application of the inhibin assay. I should say parenthetically that our group in Melbourne, Hudson, De Kretser, myself as the main investigators in the mid-70s, had been awarded a big Ford Foundation grant for our work directed towards the possibility of a new male contraceptive. And the theory, of course, was that if one could isolate a hormone like inhibin, which was a selective suppressor of follicle-stimulating hormone, that you might be able to selectively suppress spermatogenesis, for which FSH was crucial, without interfering with the male hormone function of the testis, the testosterone-producing function which gave a man his virility rather than his fertility. And of course it turned out that inhibin was far too complex a protein to make it a practical male contraceptive, but suddenly with the advent of the granulosa cell tumour finding, here was the possibility of a new diagnostic in ovarian tumours. David Healy then collected material from a lot of other patients with ovarian tumours and showed that some patients with the most common form of ovarian tumour, the serous epithelial tumour, had raised inhibin levels, and most patients with the second most common tumour, the mucinous tumour, also had raised inhibin levels. The common marker for ovarian cancers at that time and still now is an antigen called CA125, and it looked as if CA125 and inhibin measured together in samples from patients with ovarian tumours or suspected ovarian tumours or even being screened for ovarian tumours might be an excellent combination, because inhibin picked up the tumours that CA125 didn't. And David Robertson in particular was the person who moved that field along and was able to show that indeed that complementary assay was very helpful in the diagnosis and monitoring of patients with ovarian tumours.
Obviously, we now know that hormones are secreted across the day and moment to moment in different ways and different patterns. Can you remember an important development at Prince Henry's in this particular area of physiology?
One of the very important members of staff of the research centre at this stage was Ian Clark. Ian Clark had been an associate of Professor Jock Findlay, who was also a very important contributor to reproductive physiology, particularly using the sheep as a model. And we had collaborated much earlier in developing an immunoassay for follicle-stimulating hormone in the sheep. That had, for some reason, proved to be a very difficult nut to crack, but finally, with the collaboration of Lois Salamonson and Helen Jonas, we did establish a good immunoassay for FSH, which allowed Jock to pursue a lot of physiological studies in the sheep. More or less at the same time, Ian Clark had established a collaboration with a neurosurgeon from St Vincent's, Jim Cummins, because Ian wanted to be able to access the portal circulation, the blood supply to the pituitary coming from the hypothalamus at the base of the brain, using the sheep model. And between Jim and Ian, a method was established for directly sampling portal blood coming from the hypothalamus. Ian had established an assay, and in fact it was an assay which I think originally I'd established in Paul Franchimon's lab when I'd done my sabbatical, an assay for gonadotrophin-releasing hormone, the small peptide which stimulated FSH and LH secretion, particularly LH, from the pituitary. And we established an ongoing immunoassay for GnRH. Ian took frequent samples from the portal blood and at the same time measured peripheral blood LH secretion in the sheep. And Ian showed that indeed GnRH secretion was pulsatile, with pulses occurring about every 30 minutes, and each pulse was followed by a pulse of luteinizing hormone in the peripheral blood. So here we had a demonstration that indeed hypothalamic hormone secretion, at least as far as gonadotrophins was concerned, was a pulsatile secretion.
The ramifications of that observation are profound in reproductive systems.
The ramifications were indeed profound. A similar demonstration had been made almost simultaneously by a group with a different approach to the problem in the United States, but I think nevertheless Ian's was the pioneering observation. We decided that if gonadotrophin-releasing hormone secretion was pulsatile, then a method of treating women who had stopped cycling because of hypothalamic disease, so-called functional hypothalamic amenorrhea, might be able to be treated with pulsatile GnRH if we could find some way of giving it to them. And so we established a collaboration with a man called Charles Hackman, who was an anaesthetist and who helped us to design an infusion pump which would give pulses of GnRH. David Hurley was a postgraduate student who'd joined me to do his MD, I think, or PhD, I've forgotten which, at the time. And David took on this project with Charles Hackman and with research nurses. We'd been running a program to induce ovulation in women who weren't ovulating for quite a long time, and it was one of the projects in which I was very enthusiastically involved, hands-on at the clinical level. I supervised the treatment of a lot of these women. And Ian or rather using Ian's data, David and Charles Hackman and I set up a program in which women would wear this infusion pump with a needle placed subcutaneously into their tummy, and they appeared to be able to wear this without too much difficulty, and they had to wear it for days at a time, where the infusion pump gave them pulses of GnRH. And we followed with daily or second daily hormone measurements the evolution of a perfectly normal menstrual cycle of hormone secretion in response to this. And we had a number of successes in inducing ovulation and causing pregnancies in such individuals. We'd had one very famous or notorious patient under our care who was treated with a cycle of what was then the common way of inducing ovulation, which was to use FSH as the gonadotrophin to induce ovulation. And she had had what on all reviews was an impeccable cycle of appropriate dosage of FSH, and she conceived quintuplets. And that became very rapidly widespread daily news, and she lost the quintuplets one by one in the succeeding weeks after they were born. Very courageously she came back to me and said, "I still want to get pregnant, are you willing to treat me again?" And we decided we'd give her the pulsatile GnRH therapy rather than trying gonadotrophins again, and she conceived a singleton pregnancy and very happily went away to motherhood. So that was another aspect of our bench to bedside research and clinical application in employing the pulsatile GnRH technique.
The menopause has been a major focus for you for decades. How did that initiate?
My interest in the menopause was really stimulated originally by a visit from the late Dr. Jean Hales, who was the pioneer of menopause management in Australia. She was a general practitioner. She asked the advice of Brian Hudson and then myself about how she could improve the lot of women suffering menopausal symptoms, because at the time, this was in 1971, there was no treatment that was accepted here in Australia which was specific to treat hot flushes and sweats, which troubled so many women at that time. And the general attitude was paternalistic and dismissive by the medical profession. She had been recently to the United States and had seen the benefits of the beginning of hormone replacement therapy in the States. We set her up in a unit or a room in the endocrine unit where she could see patients, but she saw very few for the initial weeks until she gave an interview to a reporter for the Melbourne Argus, one of our daily papers of the time. And from there she was flooded with inquiries and interest, and we very rapidly established a menopause clinic. She worked in it, she recruited several of her colleagues. I never actually physically worked in the clinic with her, but she came to me as a mentor and advisor. She wanted to introduce research from the beginning. She did one of the earliest studies, one of the earliest controlled trials of menopausal hormone therapy in the 1970s, published in the Medical Journal of Australia. That's what really stimulated my interest, her continued discussion of issues and problems related to it. And then I had the benefit of another sabbatical leave, which I chose to take at the World Health Organization in Geneva. I had worked with the Human Reproduction Program at WHO, so I knew the organisation a little bit, and one of my reasons for going was to explore whether I might want to have a late career change and go and work in a place like that, because I had always enjoyed my contacts with international colleagues and working in international programs. And when I got to the unit where I was going to spend 6 months, I was asked if I would work on a scientific group on the menopause, which the program was going to conduct. That meant that they invited a number of experts from around the world to prepare position papers on various aspects of the topic, come to Geneva for a meeting to discuss all aspects, reach agreed positions and decide what sort of research needed to be done in the future. And so I spent most of that 6 months in the library at WHO reading almost everything that had ever been written about the menopause and becoming reasonably knowledgeable in the process. And I then acted as the rapporteur for the actual scientific group meeting, which was a very revealing and interesting experience. I met my first real live epidemiologist at that meeting. We agreed about a position paper and I wrote the final report, and that was quite an influential document worldwide after that, because it summarised almost everything we knew about the menopause and pointed out the directions for research. And interestingly, even at that time in 1981, early 81, the two key issues were, did hormone replacement therapy prevent heart disease in menopausal women, and did it increase the risk of breast cancer? They were the two key issues of that scientific group. I came back, Jean Hales involved me in more discussions and aspects of menopausal practice, and I started to go around and give lectures about the menopause because it's something I had ready-made and able to present. And that then stimulated my interest in doing some more research, realising that we didn't know a lot about the endocrinology of the menopause, and realising also that with the availability of the inhibin assay from about 1987 or 88 onwards, we might have an opportunity to see if inhibin played a role, which one forecast that it would. And so we started some early studies, taking blood samples from women who had just started to have irregular periods, and also taking blood samples from normally regularly cycling women aged between 20 and 50 to study the pattern of hormone evolution in those women. And we realised fairly quickly that particularly over 40, inhibin levels dropped as FSH levels started to rise. We also demonstrated that in the initial long cycles of women starting their transition through menopause, hormone levels were unpredictable and were clearly of no value from a diagnostic point of view, because they changed from 1 week to the next in the same individual. And so at that time we started to think about teaching that diagnostic hormone assays were not of much value in that situation. That research continued into the early 1990s, and in 1991 Professor Lorraine Dennerstein, at that time head of a Centre of Excellence for Women's Health here in Melbourne, invited me to join her in a prospective study that she planned to look at how women transited the menopause. She did a cross-sectional survey of about 2,000 Melbourne women, and then initiated a longitudinal study of over 400 women who were still cycling, who were aged between 45 and 55 at the time they were first recruited. And we took annual blood samples from them. They completed questionnaires, etc. And that turned out to be an enormously fruitful collaboration, because I was able to study at least once a year hormone levels collected where possible in the early part of the menstrual cycle, and that started to build a picture of what sort of hormonal changes were occurring. That completely confirmed the likely uselessness of hormone assays, which up to that time had been widely used in women to diagnose whether they were menopausal or not. And I finally wrote a paper which was published, which said these hormone assays have very little diagnostic value. However, of course, we measured inhibin in these women as well as the gonadotrophins and estrogen. And that allowed me to incorporate studies of inhibin into studies of transition through the menopause, and we recognised the fact that probably the very first clearly detectable event was a drop in the levels of inhibin B right at the beginning of when women were starting to go through the transition. So again, for me, that was a sort of a bench to bedside ability to apply an assay to the clinical study of women transiting the menopause. More or less in parallel with all that, I developed an active interest in menopause management and in the role of menopausal hormone therapy. And that's been an abiding interest ever since. And one of the major areas in which I have been active, not as successfully as I might have liked, was in the reaction to the American study, the so-called Women's Health Initiative study, which caused a total explosion in the hormone replacement therapy field in 2002, and resulted in an up to 80% drop in the use of menopausal hormone therapy for what, in my opinion, were totally specious reasons. The data were not fairly and appropriately presented, in my opinion, and I, from the day that study was published, have been one amongst many who have spoken out against the applicability of those findings, and that's a standpoint that has been taken by the International Menopause Society, the American one, the Australasian one, and most recently in a scientific statement published by the American Endocrine Society just a few months ago, called a scientific statement on postmenopausal hormonal therapy, and that also came to the same sorts of conclusions that I'd been defending for.
Do you see an important role for scientists and clinicians to engage in the public arena in discourse about matters such as the menopause?
I think it's an essential role. One must be there to comment. Unfortunately, given the nature of the press, they will often single out people who are of a diametrically opposite view, and perhaps a view that one would not regard as very fairly presented either. And so you often end up in a position where completely conflicting statements are made to the media, and it becomes very difficult to persuade people of a particular point of view. But I think it is absolutely essential to do that.
The name of Jean Hales continues to this day in the form of the foundation. Can you tell us a little about the early history and your involvement in that?
Jean Hales died a premature death of lung cancer in 1988, and a group of us who were closely associated with her felt that we must do something to perpetuate and to honour her name. And ultimately we founded the Jean Hales Foundation for Women's Health and developed a clinical service, a research arm and an educational arm, which has now become nationally very well known and is now significantly funded by the federal government. The Jean Hales Foundation has really become the reference point for effectively all questions relating to women's health, particularly menopausal women's health. Its present director, Helena Teed, who was one of my last registrars, is very interested in the very topical area of lifestyle influences on women's health and on the commonest women's health disorder, polycystic ovary syndrome. And Helena is leading the research arm as well as leading diabetes at Southern Health in producing an excellent set of guidelines for how women should regard their health, their weight, their exercise patterns in order to prevent future disease.
I'd like to turn to other aspects of your life now. What other hobbies and interests do you have?
I mentioned, I think, earlier in our talk that I was very interested in music. That's been an abiding interest. I love to listen to music at home. We love to go to concerts, and I mentioned particularly my interest in Baroque and classical music. I've always loved to ski, and that's given me an opportunity to see some wonderful and picturesque parts of the world. In doing that, I play tennis regularly, and I'm an avid watcher of cricket and football and other competitive sports, mainly on the television, but sometimes at the Melbourne Cricket Ground also, which is near where we live.
I believe you also have a four-wheel drive in the family, and you like to get around in the outback.
We have a four-wheel drive in the family, and we've made several trips up to the Kimberley region, which we love, and feel very fortunate in that we've now managed to see a fair part of Australia rather than just confining visits to overseas, of which we have made very many.
I think it's important to recognise the significant others in your life, your wife, your family. How have they impacted on your life at home and indeed at work?
Absolutely essential. Jenny was a student of my mother's at Melbourne University in the French department, and we met at a Bastille Day celebration in 1957, and we were married in 1959. She was a teacher of French and German for very much of her professional career, but then changed fields completely in 1987 when she did a master's degree and went on to work in the field of mental health, particularly as a carer consultant, meaning that she looks after the families of people where there is a member with a serious mental illness. And that is something to which she is devoted and which she, as I can see at least, does superbly. She's been a wonderful wife, a wonderful mother. She's a superb cook. She's my best friend. I couldn't speak highly enough of her.
It struck me in thinking about your travels overseas in particular with your wife and young family. That must have been challenging for you and particularly for her.
Certainly it was. We went to England on our first overseas trip with our first child about to turn 1 and the second child in utero. He was born in London, the third one was born in the United States, and the fourth and fifth were born back in Australia. Yeah. I think Jenny found life very difficult as a young mother without much in the way of a support network, either in London where things were a bit better, but particularly in the United States where we lived in a little house off the campus of the NIH, and that was a tough life for her. Jenny single-handedly, effectively, brought up the 5 children. She stopped working almost entirely, and I'm afraid that I probably fell short as a father who worked long hours and was persuaded for quite a long time that he should spend at least one day of his weekend playing golf, which I ultimately realised was not a profitable thing to do, and then return to the fold a bit more. Yes, we had some marvellous trips. Our sabbatical in Belgium in 1972-3 actually included the company of the youngest daughter of my mentor, Brian Hudson, who lived with us as a kind of younger sister to Jenny, and who then stayed in Belgium as a secretary to Paul Franchimont after the rest of us returned to Australia. We had camping and caravanning trips through Europe with all 5 children. When we first arrived, the French used to look at us and say, "Ah, cette famille énorme."
Yeah, right. And now you have 12 grandchildren.
Now we have 12 grandchildren. 3 of them live in Germany, 1 of them lives in Canberra, and the other 8 live here in Melbourne, and they're a great joy.
And you still have a very close family. I understand that recently all 5 children came back from around the globe to celebrate Jenny's birthday.
All 5 children planned a surprise for their mother, including the German and the Canberran residents who both came to Melbourne for the weekend, and we had a most wonderful family reunion just with them and the 2 of us. And we've of course celebrated our 50th anniversary of marriage just late last year.
Your Catholic faith and your life in medicine, particularly reproductive medicine, must have presented opportunities and also some conflicts over time.
I mentioned earlier that I was clearly brought up as a Catholic, and during my time, I think as a, possibly even as a medical student, but certainly as a resident, I got to know John and Lynn Billings, the late John Billings and Lynn, who were teaching a method of fertility regulation which they called the ovulation method, as being a method which conformed to the Catholic Orthodox teaching of the time. I was involved in teaching in a marriage preparation course, which was a course for engaged couples, and I used to give a lecture really just on reproductive anatomy and physiology and the basis of the ovulation method, not with any injunction that couples should use that, but just to inform them about its nature. In fact, I got involved in a very interesting study with the late Jim Brown and the Billings, which was able to show that the ovulation method as taught by the Billings, which basically taught women that a pattern of mucus secretion, which could be recognised in the vulva, would guide them as to when in the month they were fertile or not fertile. We were able to show, with Jim Brown and myself doing the relevant hormone assays and the Billings teaching the fertile observations to a group of 20 women, were able to show that the women were in fact extraordinarily accurate in picking the likely day of ovulation and the likely day of maximum fertility in the cycle. And that was, I think, a landmark publication in The Lancet in 1972. And I went on then to join the Human Reproduction Program as a consultant in Geneva and was asked to coordinate a 5-country study of that method to determine whether women of all backgrounds and educational levels could learn the method and how well or otherwise it would work when put into practice. What we in fact found was that more than 90% of women were able to produce a chart which was interpretable as indicative that they knew what they were looking for and what they were observing, and that if the method was applied strictly according to the rules of the method, then the pregnancy rate was extremely low. As one would expect with a method that requires periodic abstinence, in practice, of course, many pregnancies occurred. It's still a method which the Billings promote and teach, and they have programs, I think, particularly in China and Africa, but I really have no good appreciation of how widely the method is used now.
You're also a part of a group of other Catholics who gave a great deal of thought to the teachings of the Church, particularly the papal encyclical of 1968. Can you talk about that group?
We are in fact part of 2 discussion groups, one of them particularly concerned in the area that you've mentioned, a group of what could be called Catholic intellectuals, including my former Deputy Director at the Institute, Professor John Funder, who is a very widely educated man, and his then wife, who has since died, Kathleen, who was also extremely well informed, Professor of Philosophy at Melbourne University, and his wife, a psychologist married to a urologist, 2 senior teachers, and a lawyer. And we met regularly, and at that time there were 2 or 3 priests who also used to regularly join the group, and there was one who was an ex-priest who became Professor of History at Melbourne University. But when the papal encyclical on artificial contraception was issued, which reaffirmed the Church's position that this was contrary to moral teaching, one of the priests in the group actually made a public statement, which was published on the front page of the newspaper, saying that, and this man was a moral theologian, that neither as a moral theologian nor as a priest nor as a man could he give either internal or external assent to the papal statement. He, of course, lost his priestly job in the flash of an eye. Another man who was of similar views and had been Director of Catholic Education was also a part of that group and also was a dissenter. And I think all of us in the group were dissenters and just felt that we could not accept any longer that sort of teaching. And of course it has to be remembered that Paul VI, who promulgated that encyclical, had been advised almost unanimously by a special papal commission that the Church's ban on contraception should be lifted, but was persuaded by a very small number of people at the very end not to do so.
Since that time, there have been other controversies in reproductive medicine, particularly IVF, donor insemination and so on. How have you dealt with that personally and also professionally in terms of what the Institute was researching?
It's always been my view that my personal attitudes or my personal morality should not influence what was done at the research centre or the research institute unless there really were a gross conflict, and that there has never been. But for areas like donor insemination, IVF, which the Institute itself has not been directly involved in, but certainly indirectly, and I acted as an advisor to the early weeks or months of the establishment of IVF here in Melbourne, my personal attitudes were that I was in a pluralist society and that I respected the views of others and that I was certainly not going to impose my views on them.
Tell me now about what you think were the most important and significant overseas experiences that you've had.
I would have to go back and say that the early experiences of postgraduate training were significant. I won't go back over those. The ovulation method survey in the 5 countries, which included countries like the Philippines, South India and El Salvador, that experience was a wonderfully enlightening one and opened my eyes to just what poverty in other parts of the world really meant and how delightful it always seemed to be to work with overseas colleagues. In 1984-5, I was appointed a Sims Commonwealth Travelling Professor, and that involved visiting Zimbabwe, South Africa and subsequently the United Kingdom. Apartheid was very much alive and well in 1984 when we visited South Africa. I enormously enjoyed the experience of seeing and working with South African colleagues, and most of the ones that I encountered were actually seriously anti-apartheid. The man who mostly looked after us in Cape Town and from there on was somebody who had vigorously fought apartheid in his own hospital and to the extent he could do it. Many of his colleagues had left South Africa because of that problem. He had chosen to stay and fight, and I had enormous admiration for him. His name was Solly Benatar. That trip was one that was highly significant. I did make many trips overseas to attend and speak at international conferences and serve on advisory boards, etc. And I suppose for a number of years I was travelling overseas between 5 and 8 times a year. All of which I enjoyed, all of which I found to be a great privilege to be able to interact with colleagues overseas who were inevitably hospitable, generous and a delight to work with.
You also visited China in the early days, in 1983, I recall.
I went to China in 1983 for the World Health Organization to teach a course in andrology, a specialty we haven't talked about today, but in which I was very active with David de Kretser and others in the early 70s and 80s. And I went to teach a course in andrology in Beijing at a time when there were very few cars on the road. Everybody still wore a Mao suit and rode a bicycle, and that was a very interesting experience.
You also had some extraordinary experiences travelling and teaching in Eastern Europe. Would you like to talk about that?
One of the aspects of my involvement in the menopause that I didn't mention was an involvement with the International Menopause Society, with which I became associated probably in the mid-1980s, and I became president of that society in 1996 and decided that in 1998 we would make a visit to Eastern Europe because I was very concerned that there was very little connection between the Western European-based International Menopause Society and its Eastern European counterparts. And so we made a trip which began in Yugoslavia and included Romania, Bulgaria, Hungary, Poland, and Russia. A trip which was marked by, again, enormous hospitality, enormous warmth, and I think a successful outcome in that from there on, Eastern European representatives started to play a much bigger role in the International Menopause Society.
Over your career, you've received many awards and invited speakerships, but there must be some that stand out in your memory as being particularly significant. What are they and what was it about them that made such an impact on you?
Important to me was the promulgation of the name of Prince Henry's Medical Research Centre and the making known to colleagues overseas that we were actually doing worthwhile work. Now, in part, of course, that's achieved by publishing in internationally recognised journals, and our staff were successful in doing that. But there was also the aspect of being recognised by awards from international colleagues. And I suppose the first significant one of those was in 1981 when I was asked to give a state-of-the-art lecture by the American Endocrine Society, which didn't invite too many foreigners to speak at its meetings, to talk on testicular inhibin. So that was one of the initial big events for me. Subsequently, I was also asked by the American Endocrine Society to give a plenary lecture at one of its meetings in the late 1990s, where I talked about our work on the endocrinology of the menopause. I was recognised by the British Endocrine Society by the award of its Dale Medal, which is its highest accolade. I was recognised by the American Endocrine Society with the Distinguished Physician Award, and with my involvement in the menopause was given 2 awards about 6 years apart by the North American Menopause Society, one for the work on perimenopause and the other for work that we haven't talked about today, the use of androgens in women, particularly women with disordered sexual function.
And also in Australia, you're awarded the Harrison Lectureship of the Endocrine Society of Australia.
That also meant a lot in terms of being recognised locally. I was, of course, thrilled to be elected to Fellowship of the Australian Academy, and I was also thrilled to be given an award at the honours list as AO.
Granted that your publication record's been extraordinary, you have over 600 manuscripts, what else do you regard as being your major achievements in science?
I think probably the most enduring achievement, if I set aside family life, has been what I would humbly call the successful leadership of Prince Henry's Medical Research Centre and Prince Henry's Institute as it became, with incorporation under Victorian State Act of Parliament in 1990. And I had the privilege of leading the Institute essentially from 1965 to 1998, and I think was able to build, by virtue of the excellence of the people who came to join us, a first-class, productive institute, which I would like to think of as being Australia's leading endocrine research institute. I led it, I think, with values of the absolute importance of integrity and honesty, of collaboration and cooperation, of joint leadership. I always had all the senior scientists of the Institute as members of a senior advisory group and took no decisions for the Institute without consultation with them. I attempted to ensure that the working environment was conducive to work satisfaction and good relationships, and I must say occasionally exercised my discretion in not appointing people who I thought would not work in accordance with that sort of principle. Clearly I was very strong in encouraging young people, and particularly in my later years encouraging women in endocrinology, and was fortunate enough to train a substantial number of endocrine registrars and PhD and MD students, many of whom have gone on to leadership positions in endocrinology.
So what was your approach to the direction of the Institute and the work that was undertaken?
As I mentioned, my philosophy was always to hopefully attract first-rate people who would work in the broad area of endocrinology and to foster their research and to rely on the fact that they were people of excellence who would be productive and would make significant contributions. In the early years, after Brian Hudson had left to go to the Florey, a major individual to join the Institute was Professor John Funder. And Funder was an expert in salt-retaining hormones and had been crucial to the identification of the cellular receptor for aldosterone, and he continued his work in that field, served as Deputy Director of the Institute for many years, was a major contributor to scientific dialogue in the public domain, a brilliant speaker, and I think served the Institute with great distinction. He subsequently became Director of the Baker Institute, but after stepping down from that, rejoined the Institute and is now still working at the Institute in a part-time capacity. Other significant people who were members of staff: Lois Salamonson, one of our original graduate research assistants, came back to do a late in career terms PhD and subsequently headed a uterine biology group, which I think has made superb contributions in the whole area of menstrual bleeding disorders, implantation of the embryo, new approaches to contraception. She has really had a star-studded career in contributing in that area. Harry Majewski, a pharmacologist, joined the Institute in 1990 and was with us for 10 years. He was interested in cardiovascular pharmacology. Helena Teed, whom I mentioned, did some postgraduate work under his guidance. He provided a new opportunity in the Institute, brought new research students, and I think again made a highly significant contribution. Evan Simpson subsequently joined the Institute and eventually became its director, and his work in breast cancer research was pivotal and resulted in the Institute becoming a member of the Breast Cancer Research Consortium here in the state of Victoria, making important contributions to knowledge and leading to the establishment of a collaborative group of people who regularly talk to each other about breast cancer research.
So Henry, you're 77 years old now, and it's been 12 years since you retired as Director of the Institute. But in that 12 years, you've had 120 papers, you continue to see patients. Every Monday morning you come to Journal Club at 8 o'clock, and every lunchtime you contribute to the clinical discussions of the unit in a very active way, and the resident staff really value your insights enormously. So with that in mind, can you talk about what the word retirement might mean?
I think the word retirement is a difficult word to understand. I would say that I regard myself as being in the extraordinarily fortunate position of being able to do the things that you've just mentioned. My successors as director of the Institute, Evan Simpson first and then Matthew Gillespie, were both very welcoming to me to stay, at least to have access to an office and secretarial help and the privileges of library communication. They could easily have said, "You've been here so long, we would rather not have anybody peering over our shoulder." I accepted that hospitality on the condition that I would have absolutely no involvement whatever in the administration of the Institute once I had stepped down. Retirement has certainly meant an easier pace of lifestyle. I do 2 half days of clinical work. I keep my hand in a few research projects. I still referee quite a lot of papers for learned journals and act in a consultative capacity to various bodies who seek review of statements and advice about those sorts of things. But I do it in a fairly leisurely fashion. I spend probably 3 days a week still in front of my computer at home, but weekends are longer. I'm able to relax a bit more and read a bit more widely. So retirement so far has meant a gentle modification of what I did before, and that's the way I see it rolling out from here on.
So Henry, thank you for being here today and sharing with us your life history and your insights into science, clinical medicine, and indeed life in general.